The use of telehealth skyrocketed during COVID. Virtually overnight, 40% of doctors' visits for older Americans were over the phone or on video. One key reason for the explosion, Medicare and other insurers started paying for the service. There were high hopes telemedicine's convenience would improve care and lower costs. But there was also some real fear that extra appointments would drive costs through the roof.
The concern of telehealth has been that its convenience is its Achilles heel.
Today, as Congress figures out the future of telehealth, we get a reality check from a top researcher about what this care has and has not delivered. From the studio at the Leonard Davis Institute at the University of Pennsylvania, I'm Dan Gorenstein. This is Tradeoffs. $66 million older Americans today who have Medicare can call or video chat with their doctors from their couch. But that could end by 2025 when the rules governing telehealth and Medicare are set to expire. That puts in jeopardy patients' ability to see and talk to their primary care providers, cardiologists, or other specialists from home. Congress must decide whether to keep these rules in their temporary status, develop permanent rules, or wind back the clock pre-COVID era when these visits were mostly uncovered. To make this decision, lawmakers are hungry for evidence, what's working, what's not, and how much telehealth costs. Dr. Ateev Mehrotra has been going through the data. He's a professor at Brown University School of Public Health and has studied telehealth for a decade. As a skeptic by nature, Ateev says he wants to understand whether the promised innovations are all that they're cracked up to be.
I think there's been a lot of excitement about telehealth, but I also recognize that a lot of what's out there that people are pitching as going to be a new revolutionary idea is a bunch of crap or is just not going to work. And so I do feel that there's a real need for good evidence. Does it work? Does it not work? And if it does work, how can we make it better?
So when COVID-19 hit, the federal government started requiring insurers to pay for phone calls, video calls with our doctors. And I remember, Ateev, in that moment, I'm sure you do too, there was both hope and hype and some concern. I want to walk through this across a couple of different metrics. Let's start with quality. When it comes to quality, Ateev, what was the hope and what was the reality?
Yeah, the hope is that the use of telehealth will allow more people to get care and will lead to substantial improvements in terms of chronic disease management or people accessing care that otherwise couldn't have got treatment. The concern was video visits and phone visits, they're just not up to par. And actually, this is going to negatively impact the quality of care that Americans receive.
What has the research borne out?
So I think the answer is somewhere in between, which is kind of frustrating, but that's just the nature of what research is all about. In some clinical areas, we have found that it has led to substantial improvements. But across the board, the improvements are relatively small in nature. For example, in one study, we found a small improvement in medication adherence, but not the big improvements that people had hoped. But also, I don't see any evidence that it's negatively impacting quality. If anything, it's improving quality modestly.
So marginally improving health. Ateev, that leads me to the next category, which is spending. Is that marginal improvement worth it? Like, what was the hope? What was the hype? And what's the reality around spending?
The hope has always been that people who get more telehealth would better manage their chronic illness, for example, say diabetes or high blood pressure, and that would decrease hospitalizations and ED visits, and therefore the savings from those fewer hospitalizations and ED visits would save the healthcare system money. So that's the general way that people have hoped that telehealth can save money.
Healthier people, fewer hospital visits, fewer, as you say, ED visits, which are emergency department visits. It sounds like people thought telehealth would achieve the holy grail of healthcare innovations. Ateev, what was the concern with spending?
Yeah, the concern of telehealth has been that Making care really convenient will lead to more people getting care, and the care that comes from that will increase overall healthcare spending substantially.
And drum roll, the results?
Somewhere in between.
Ateev, this is like Groundhog Day with you, dude. You do know it. You know it's May, man.
Exactly. I have seen no evidence that telehealth is decreasing healthcare spending. However, the increase was not as large as I had expected, but we're seeing something in my work about a 1% to 2% increase in spending.
So marginally improving health. Okay. And when you talk about small improvements in medication adherence, you're talking about people being more likely to take their meds. Ateev, that leads me to the next category, which is spending. Is that marginal improvement that you're talking about worth it? What was the hype and what's the reality around spending?
I believe that the benefits that we're seeing from telehealth are worth it. And it's clear that the American public really wants it to be around. But how do we make sure that telehealth is being used in the most cost-effective or high-value way?
How do we get the most bang for our buck with telehealth? That's one of the policy questions Congress is wrestling with right now. Another related one has to do with access. Lots of folks who talk about people in rural areas who are many, many miles away from providers were excited about telehealth closing some disparities. Ateev, has it in fact done that?
So the concern has been that the very nature of how you use telehealth, you got to use technology, a smartphone, broadband connection, a computer, that there is a digital divide in the United States, and that this could actually widen the disparities. And unfortunately, the evidence is that the rural patients are much less likely to receive telehealth visits. So that, I think, has been quite concerning. As we think about telehealth deployment right now, it could widen the existing disparities in the U.S. healthcare system.
We just talked about the rural-urban disparity, but what about other kinds of disparities? Has telemedicine helped patients of color or low-income people get better care?
We had hoped that telehealth will be used by those who are most struggling to access care. Unfortunately, we're finding the opposite, and that within a community, we're finding that Hispanic patients receive fewer telehealth visits than non-Hispanic whites, and the difference is pretty substantial, 13% fewer visits. The bottom line is we as a society need to invest more in terms of what tools can we deploy to ensure that all Americans have access to a telehealth encounter, and in particular, a video encounter or a video visit.
After the break, Ateev translates his telehealth research into recommendations for Congress and pinpoints the area of telehealth that leaves him most excited.
Ready to start talking to your kids about financial literacy? Meet Greenlight, the debit card and money app that teaches kids and teens how to earn, save, spend wisely, and invest with your guardrails in place. Parents can send instant money transfers, automate allowance, and more. Plus, keep an eye on spending with real-time notifications. Join more than 6 million parents and kids building healthy financial habits together on Greenlight. Get your first month free at greenlight.com/ACAST. That's greenlight.com/ACAST.
Welcome back. We're talking with Ateev Mehrotra, professor at Brown University School of Public Health. So, Ateev, Congress has until the end of the year to either return to much more restrictive pre-COVID rules, make permanent new rules, or just temporarily extend these flexible ones that we're living with right now. Please, sir, put on your prognostication hat. Which of the three doors do you think Congress is most likely to choose, and why?
Door number 3, Dan, which is called the kick the can down the road door.
One of Congress's favorite moves, yeah.
Given the evidence that's emerged, a permanent expansion of telehealth is going to increase Medicare spending. How are you going to pay for that? And that's a difficult policy question. I think there's general enthusiasm for making permanent policy, but in this political environment, in the setting of a presidential election this year, I think the kick the can down the road is likely the approach that the Congress will take.
As lawmakers have been deciding what to do, they called you, Ateev, to testify. They wanted to hear what changes to the rules you would make. Let's talk through 2 of them. The first is about phone calls. Right now, Medicare covers those calls just like video visits. But it sounds like from what you told Congress, you are not a huge fan of these audio-only visits. Can you explain?
Yes. I am concerned about audio-only visits for several reasons. One is that they may be more prone to overuse. And second, there are some places where I don't feel just a phone call is sufficient. And so I would prefer a system where everybody uses video visits, because I'm concerned about a future with a 2-tiered system where the poor receive phone calls and the wealthy have video visits.
Personally, I guess I've always thought about phone visits as a way for older patients who don't know how to do video chat, or rural patients with like really crappy internet, as a way to have telehealth. Is there another reason you're worried about this like 2-tiered system that you're talking about?
One underappreciated reason that some patients receive a phone call is that their clinician, their physician, nurse practitioner only offers them a phone call. It's because some practices don't still in 2024 offer video visits. And in other cases, they're making assumptions that this patient can't do a video visit, so I'm only going to offer them a phone call. We should make sure Medicare and other payers require clinicians providing an audio-only visit to say, look, I offered the patient a video visit and the patient asked for the phone call. I didn't assume.
I see. So it's important to you that the patient gets a choice. Another tweak to the rules that you're suggesting is payment. Right now, Medicare pays the same for a telemedicine visit as an in-person visit. Many hospitals and doctors want that to continue. You can imagine why. They say even if they offer telehealth visits, they still have to pay overhead, the building, staff, all these things. You say, though, that doctors and nurses should get paid less for telemedicine. Why?
Telehealth visits do not require the same overhead and therefore should be paid less. That's one reason. The second reason is that I am concerned if we pay the same amount, we'll introduce new distortions in the market. It will give virtual-only companies a competitive advantage.
Right. Your point is that virtual-only companies, because they have less overhead, would have a leg up against brick-and-mortar providers like physician practices and hospitals. Okay, so Ateev, we've talked a lot about what the evidence on telemedicine shows right now. Let's look forward. What's one area of telemedicine that you think has the most promise in terms of efficiency and effectiveness?
One that I have been particularly excited about is remote patient monitoring. That's the idea that a patient with, say, high blood pressure, I give a blood pressure device that's Bluetooth enabled or cellular enabled, and I say every day, check your blood pressure, and it's going to come to me, and I'll adjust your medications. And so remote patient monitoring facilitates a better type of care, which I am excited about, that proactive model.
Evidence on that is emerging. I look forward to checking in with you in a few years about whether these devices are delivering on the hopes. Okay, final question, Ateev. If Congress continues to practice the temporary policymaking around telehealth, is there a downside?
If you were the chief financial officer of a big health system or running a small practice, do you invest or not? And that's hard when there's just the kick the can down the road strategy because you're not sure. And at the end of the day, money's tight and you may choose to not make those investments that you want. So I think that's the real downside. This sort of keeping telehealth in limbo has sort of pushed off a lot of these decisions and in some ways is discouraging telehealth in the U.S. healthcare system because clinicians are unwilling to make those investments given that uncertainty.
Ateev, thanks so much for taking the time to talk to us on Tradeoffs.
Thank you for having me.
As Ateev predicted, Congress appears to be kicking the can down the road. 2 different committees in the House have voted to extend the rules for another 24 months. The full House and Senate face an end-of-the-year deadline to act. I'm Dan Gorenstein. This is Tradeoffs. What do Costa Rica and Baltimore have in common? A radical approach to providing primary care.
Go ahead and just take some deep breaths. It's gonna get a little tight, okay?
At least that's the dream of an ambitious group of Baltimore nurses, to bring primary care to everybody, no matter their age, income, or insurance, and deliver it right to people's doors.
We need something that's completely different.
We go inside this bold attempt to import universal primary care from Costa Rica to America. Next time on Tradeoffs.
Thanks for listening to Tradeoffs. If you've just discovered us, remember to subscribe to the feed so you never miss an episode. Subscribing is free and easy on whichever podcasting app you use, the NPR app, Apple Podcasts, Spotify, wherever you listen to podcasts. The Tradeoffs team is producers Alex Olgan and Ryan Levy, editors Kate Cahan and Deborah Franklin, executive director Jessica Silverman, marketing director Catherine Dougal, audience engagement lead Shannon Crane with help from Kate Seepy, Kelly Osmondson, and Cedric Wilson, sound designer Andrew Perella, executive editor Dan Gorenstein, and senior producer Leslie Walker. The Tradeoffs theme song was composed by Ty Sitterman, with additional music this episode from Blue Dot Sessions and Epidemic Sound. Tradeoffs coverage of Medicare sustainability is supported in part by Arnold Ventures. Additional thanks to Brian Hasselfeld, Mei Kwong, and Taki Michaelidis. Thanks also to all our listeners who helped to support our work, including Jonathan Miller, Laura Lane, and Alexandra Schweitzer. Our media partner is Side Effects Public Media, based at WFYI. Tradeoffs is supported by the Robert Wood Johnson Foundation, Arnold Ventures, the Gordon and Betty Moore Foundation, the Sozoze Foundation, Just Trust, West Health, the California Healthcare Foundation, the Leonard Davis Institute at the University of Pennsylvania, and the National Institute for Healthcare Management Foundation. Our financial supporters are not involved in any decisions about our journalism. The views expressed in this episode are those of the individuals and not those of Tradeoffs staff, advisors, or funders.
My business used to be weighed down by the complexities of in-person payments. Then, Tap to Pay on iPhone and Stripe came along and changed everything. With Tap to Pay on iPhone and Stripe, I streamlined my payment process effortlessly. Now I can accept in-person, contactless payments right from my iPhone. No extra hardware required. What's truly remarkable is how I can cater to all of my customers' payment preferences. Whether they're using cards, Apple Pay, or other digital wallets, Tap to Pay on iPhone and Stripe ensure a smooth checkout experience every time. And it's not just me. Stripe helps businesses of all sizes, from local markets to global retailers, scale quickly and stay agile. To learn how Tap to Pay on iPhone and Stripe can help grow your revenue and reach, visit stripe.com/tapiphone.